Hello everyone, welcome back to my channel Connect Radiology, where I'm trying to make things simplest for you. So today's topic of discussion is actually intrauterine linear echogenicities in the gravid uterus, or the ILEs, or in simpler terms, the intrauterine membranes in pregnancy. So let's discuss the basic anatomy of the fetal membranes first. So see, when the fetus is actually smaller, this blue color innermost membrane is the amnion. Just outside this, pink color is actually the chorion, and beyond this is the decidua. This developing structure, pink color structure, is actually the placenta, which is also covered by the amnion and the chorion. The umbilical cord connecting the fetus to the placenta is also covered by amnion and chorion. As the fetus grows, it obliterates the uterine cavity, but is still, see, this is covered by innermost amnion, then the chorion, and finally the decidua. This is the developing placenta. And if we want to see the cross section of this placenta, the side of the placenta which is facing the fetus is actually the chorionic plate, which is covered by the amnion and the chorion, and the part which is facing the maternal side is actually the basal plate. So this is the basic anatomy of the membranes that you should know. Where is the amnion located, where is the chorion located? Okay, now let's see the early stages of pregnancy, where we can see the developing gestational sac. So this structure is actually the developing embryonic pole, which is within this amniotic sac. This is actually the amniotic membrane. This is within this amniotic sac, and this embryonic pole is attached to the yolk sac. As the embryonic pole grows, see, this is within this amniotic membrane. This fetus is within this amniotic membrane, and it has detached itself from the yolk sac. Okay, so these are the early stages of development of the gestational sac, and this is actually the chorionic plate, which will further develop into placenta. Okay, it will further develop into placenta. Now let's discuss the basic membranes. So first is actually the amniotic shelf. The amniotic shelf. So we will look all the membranes from 3-4 perspectives, like why they form. Okay, so these amniotic shelves are actually formed due to the pre-existing uterine synecdoche. From where the synecdoche came, these synecdoche can form in previous pregnancy, previous cesarean section, DNC, any previous endometritis. So in these situations, uterine synecdoche forms, and when pregnancy happens, the amnion and the chorion grows over them, the synecdoche, and form these membranes. Okay, so how to identify these membranes? These membranes can be located anywhere in the uterine cavity, and the site of attachment is actually uterus to uterus. Okay, uterus to uterus. Placenta can implant over them, but usually the attachment site is myometrium to myometrium. Usually they are very thick because 2 layers of amnion, 2 layers of chorion grow over them, and they become thicker. Okay, see, this fetus is totally free from this amniotic shelf. It does not cause any fetal malformations. So these are the amniotic shelf. Main thing is their attachment, which is uterus to uterus, and they are thicker in thickness. Another differential of intrauterine linear echogenicities are the amniotic bands. Why they form? Because of the rupture of amnion. So it can be multiple in number. How to identify them? They attach the uterus to the fetal parts. Remember, it's not like uterus to uterus. It's always from the uterus to any of the fetal parts, whether it can be umbilical cord, it can be fetal limbs. And see, in this case, due to attachment to the fetal limb, it has caused constriction band and marked edema of the distal limb. Okay, these, as they are formed just of amnion, so they are very thin in thickness. Okay, and they cause many fetal malformations. The third differential is actually the circumvallate placenta. Now, why circumvallate placenta forms? Because we already know that one is basal plate and one is the chorionic plate. So when the chorionic plate, which is facing the fetus, is smaller, so the membranes which covers them are actually redundant, and they form just shelves along the edge of the placenta, and when we move the probe, we can see linear echogenicities attaching from one placental edge to the another placental edge. It will be parallel to the orientation of the placenta. So now we know where it attaches. It attaches placenta to placenta, and they are usually thicker in thickness. So see, this is actually the circumvallate placenta, where we can see the rolled edges of placenta, and the orientation of this membrane is parallel. Okay, now the fourth differential is actually the uterine septums, the duplication anomalies of uterus, like in septate uterus or in bicornuate uterus. Like for example, in this septate uterus, we can see a thick septum. So where they will attach. Okay, so they will be located in the fundus of the uterus, and they are very symmetric, very thick because of the myometrium. So in this image, we can see the developing G-sac, and here we can see the smooth fundal contour, means it is not a bicornuate uterus, and there is this thick septum. So these septums will be located in the fundal region and grow as like along the length of the uterus according to the type of the anomaly. In this image also, we can see a thick septum arising from the fundus of the uterus, and they are usually very thicker. Placenta may implant over these septums also. Okay, so see this thick uterine septum arising from the fundus. So their main identification point is their attachment, their origin from the fundus of the uterus. They are very symmetric and they are very thick. Now let's just summarize the ILEs in the gravid uterus. So if I want to classify these ILEs, we will classify it as the uterine, then the placental, and membranous. Okay, Amongst the uterine, it will be like a uterine duplication anomalies, the synecdoche or the amniotic sheet or cells. Amongst the placenta, it will be like circumvallate placenta, and amongst the membranes, it will be amniotic bands, it will be body stalk syndrome, and it will be chorioamniotic non-fusion or chorioamniotic separation, and hemorrhage in between the membranes. Okay, these two I'll discuss in some other videos. And when we are talking as hemorrhage in between the membranes, means we are talking about the twins and the intertwin membrane in cases of dichorionic diamniotic and the MCDA twins. Okay, so whenever we are looking at the ILDs, we can think about these classifications: the uterine, the placenta, and the membranous. And we have to ask few questions like about their location. Like in the uterine duplication anomalies, their location is fundal. In the synecdoche can be located anywhere. These amniotic bands can be located anywhere randomly, and the circumvallate placenta is along the placenta, their location. Next is their attachment. So this duplication will be attached to the myometrium up to a variable length into the uterine cavity. Synecdoche are myometrium to myometrium. This circumvallate placenta is placenta to placenta, while this amniotic band is from the uterus myometrium to the fetus. So their attachment is important. Next thing is their thickness. Okay, so these uterine duplication septums are very thick. These synecdoche are thicker. The circumvallate placenta is also like thicker, but these amniotic bands are like very thin and wavy. Okay, next is their involvement of fetus, placenta, or the cord. Okay, like in the uterine duplication, the placenta can grow at the septum. In the uterine synecdoche, the placenta can grow over the synecdoche. In cases of amniotic bands, the band will involve the fetus or the umbilical cord. So we have to look for their location, we have to look for their attachment, we have to look for their thickness and the involvement of the placenta, the fetus, or the umbilical cord. Okay, so whenever you are getting an ILE in a gravid uterus, first of all you have to ask yourself whether it is singleton pregnancy or a twin pregnancy or triplet, multiple gestational. Whenever there are multiple gestational, we are dealing with the intertwin membrane. But whenever the pregnancy is singleton, then we have to look for the location of this ILE, whether this is located in the fundal region or non-fundal region. Then we have to look for this attachment, the attachment, whether it is uterus to uterus, uterus to fetus, placenta to placenta, okay, or placenta to the fetus. Then we have to look for some other things like their thickness, involvement of fetus, placenta, umbilical cord, and the blood flow through them. Okay, so these are the basic things when we have to ask ourselves, and the diagnosis becomes clearer. I think I have made this topic easier for you. Let me know in the comment section if you have any doubts. Thank you.